To the end of today, we're going to finish out on our obstructive diseases, part 2. And the first one that's up is asthma. So how many of you either have some level of asthma, whether it's exercise-induced or allergy-induced, or know somebody that has asthma? Okay? All right, so it's a very prevalent disease. I have asthma. It was much worse when I was a kid. I was never hospitalized for it. My brother was. He was hospitalized a few times for it. It's actually a little scary. This was long enough ago where the medications weren't quite as dialed in as they are today. And I can actually remember as a kid when we got our first nebulizer to bring home. Prior to that, we always had to take my brother into the hospital to get a nebulizer treatment. There wasn't like a home version of it. And as I got older, it sort of faded. It's definitely faded quite a bit. And I consider myself pretty active. And I don't take any medication, or I didn't take any medication for the longest time. Probably a good 20 years. And I was taking out a new insurance policy, and they told me, because of my age, I had to get a physical. So I went and got a physical, and my primary care doc, pretty knowledgeable in this space of asthma and pulmonary diseases, he said, you know, I've seen your records that you had asthma, or you have asthma, because I have an inhaler, a rescue inhaler, but I hardly ever use it. If I, mountain bike or skin up the mountain or go on a long hike, I don't usually remember to bring it. So it's not something that I ever really think about. But he said, you have a script for it, and so you obviously need it periodically. It's usually when I get sick. I don't get sick that often, but if I get a chest cold, it usually hits my... if I get a cold, it usually hits my chest, and then my asthma symptoms flare up. My inhaler is something I have to reach for. So he said, well, let's just do one of these spirometry tests. I was like, is that required for this insurance policy? No, but I'm just curious. So I took the test, and the reason I know these numbers is I was in the upper 60s. I'm like, wow. It's like, I don't feel like I have any symptoms at all. He said, you probably got used to it. And so I had to do some soul searching because I lecture on this topic. And I started thinking, I was like, all right. So I went back and saw him again. So he put me on a long-acting inhaled local corticosteroid. And so let's just try it, see what happens. Don't change anything. You don't bring the inhaler anyways, which he lectured me on that. He said, well, so don't bring it still. And, you're probably one of those types that time, I do. I time all of my activities. So I'm just trying to see if I'm getting better or worse. And lo and behold, I started noticing my time really improving and feeling less out of breath, even, on all the same stuff that I normally do, having just that much more energy. And so I've been doing it for about 6 months now. This, what is it? I think it's Symbocort is the name of it. And so I did a lot of diving into the literature on this topic that I was just mentioning to you, which I never really brought it up at that level in lecture before. But just because of my recent experience, I've read into the primary literature quite a bit. And it does demonstrate that patients who have chronic symptoms that are untreated, whether they recognize them or not, they're there if you do spirometry measurements, that over decades of unmanaged, that on autopsy, these patients had higher levels of inflammation within their lung epithelium than patients that were managed. Okay, that was one report. Second one was that they were more at risk of developing respiratory cancer or lung cancer, independent of smoking. I mean, I don't smoke. It would be silly to smoke as an asthmatic, but the long-term issues of developing lung disease are there because of this basal level of inflammation that I just got used to. So we went through this cancer lecture of things that can cause cancer are inflammatory diseases. So I kind of had to listen to my own advice, and I've been, I don't like to take medicine, so that's why I never carry my inhaler. But now I take this daily local acting. I'm noticing a huge difference. And so the only reason I like it is because now I'm faster, and I can do the same stuff even better, and I'm a year older. So it's like, all right, I'm getting a little bit better even as I get older. But I think it's because I'm becoming a little more aware of what's actually happening in my own personal health. Okay? So I say that only because I just recently went through it. So here's what's going on with asthma. So I am an asthmatic, and I didn't think that I really had any symptoms, but I really still did. Now, my FEV1s are not quite like Michael Phelps, but I also have 12-liter lungs, right? I think they're like 9.10, 9.99. So the asthmatic is either an extrinsic or an intrinsic problem. And the categories of extrinsic are going to be things typically that would categorize themselves as being outside the body. Okay? So things like smoking, ozone, pollution, allergens, obesity. What do you mean obesity? Outside of the respiratory anatomy. So obesity can cause extrinsic asthma because now the patient has extra mass that they have to move with every respiration. Okay? And that can actually wear out and fatigue the respiratory muscles and can cause some irritation of the bronchial lining. The protective exposure to microorganisms, this one is kind of weird, right? So in a lot of cases, if you're going to be exposed to a microorganism, then you're going to bronchioconstrict in order to keep it out of your respiratory tree. So microorganism contamination could trigger a bronchial constriction that's going to be extrinsic asthma as a result of a protective mechanism. Now the intrinsic ones, there's no IgE, so it's not allergy-induced, right? Intrinsic would be things like cold or exercise-induced or stress. You're like, what do you mean cold? Well, cold, if it's cold air that you're breathing in, then the respiratory bronchioles become cold. So the architecture is cold, and that intrinsically is influencing a constriction. Stress, high levels of stress can cause bronchial constriction. That's intrinsic because that's within your body. Exercise. When you exercise, the forcing of air in and out can cause irritation of the lining and cause bronchial constriction. Okay, so if we think about a normal airway shown here, nice and wide open, and then a constricted airway in an asthma attack, where that bronchial lining is actually constricted down. This is the difference between the ability to move air from this cross-sectional area to this one. Now, if we look at this panel, this is a very busy panel, but what I want to focus on up top that reads down low is there's an immediate response and then there's a late response. And both of these responses, or responsi, would be indicative of something that's going to happen as a result of, say, an inflammatory episode. Right? So, for example, in this specific, we say, here's a piece of pollen, right, that's going to present, and this is going to be a IgE-mediated response. And so you can see our helper T cells, and we can see the mast cell response. Here's our IgE-mediated response, releasing all sorts of chemical mediators. These chemical mediators are things like histamine, right, interleukins, things that are going to secrete are going to be secreted and are going to trigger the recruitment of nearby cells. And those nearby cells are going to be things like eosinophils in the early phase. And these mediators are also going to have activity on the goblet cells of the epithelium to increase mucus production. Right? The idea is the mucus is there saying, all right, I want to try to capture the irritant that's causing the problem. So let's upregulate the amount of mucus. That'll catch it. In addition to that, the recruitment of the cells are coming to the area because the early recruitment is saying, all right, I need to get cells there because there's some foreign invader that I'm seeing, and I need ultimately in the late-term response to blow the whistle and recruit my early responders, which are going to be what cell types for inflammation? Neutrophils. And then my longer-term responders, which are going to be, or my second responders, what cells are those going to be in inflammation? Are macrophages. And so you're going to eventually recruit macrophages. This one in the hour time point is only showing the neutrophils. And if this goes, like in my situation, chronically, unmanaged, instead of seeing neutrophils hanging up here, you're going to see what cell types? Macrophages. And it's not like my physician did a respiratory biopsy, but we walked through it. It was kind of this, nerdy conversation. It was a lot of fun. And I was like, oh, wow. And he's like, yeah, I'm not going to biopsy your lung. Really? Just he's like, no. But I bet you're right. I bet there's going to be lots of macrophages there. All right, you won't put any money on that bet? And so he didn't biopsy me, but we do believe, both of us concur, that in a late-term chronic response in Keller's lungs, pre-Symbicort, we would have seen macrophage presence. Okay? So this is asthma. What does this look like microscopically? Well, let's dim this light. And let me readjust the lighting here. So the microarchitecture that we're going to appreciate on our first image, we've got between this bronchial cartilage that you see on the left, bronchial cartilage that you see on the right. Bronchial cartilage, yeah, you're going to see bronchial cartilage here on the right. And then you see the lining over here of the submucosa. In between that, there's a ton of stuff. This is all fluid, edema, hypertrophy of smooth muscles, and mostly eosinophils and neutrophils that are filling this space. So if we blow up at higher magnification here, you can actually see the eosinophils, which are these structures right here that are starting to degranulate as they dump their content. Here you can see a couple little granules right there. There's one right there. So these eosinophils are starting to degranulate, dumping their contents in this asthma response. So this is the kind of picture that I wanted to get, but I didn't get of mine. Right? So here you got eosinophils degranulating in this cartoon, and that's what you're seeing down here. If you look very closely, you're seeing some eosinophil-like shapes right here. There's two granules right next to it. Here's like 4 or 5 granules right there. There's 2 right there. There's 1 right there. Okay, so they're degranulating as they're stimulating this defense mechanism to try to combat this invader that's come in. Now, the last one in our category of obstructive is bronchiectasis. Bronchiectasis. So bronchiectasis is going to be permanent dilation of the bronchiole. Usually, there's a persistent obstruction that's taking place, like in the case of cystic fibrosis. And cystic fibrosis is an inherited disease, CF. It causes a really thickening of the mucus, very sticky to build up in the lungs as well as in the digestive tract. It's the most common chronic lung disease in children and in young adults. And if it's aggressive, unfortunately, it can be lethal. And so that's one of the main causes of bronchiectasis, or a chronic necrotizing infection, an infection that goes on and on and on without any clearing up. And so the sputum, or the product that's coming out, is going to be in large amounts, or copious. It's going to be very foul smelling. It's going to smell like an infection. Patient will have shortness of breath, a cough. They'll have a fever because they have an infection, and now that infection is spreading systemically. And they're at an increased risk of continued bacterial infection as time goes on. And in this gross image, see these little blowout holes right here? All of these little blowout holes were full of mucus in this particular lung at autopsy. All right, so our last little segment for today are restrictive. That was all obstructive. Restrictive are a little less common. They're disorders or diseases that cause a reduction in the expansion of the lungs. So if we go back to this review slide, reduction in the expansion of the lung or a reduction in the total lung capacity. The expiratory volume is typically normal, so this is really heavily focused on inspiration. And these are most obvious during an inspiratory challenge versus an expiratory challenge. Now, the types of diseases and characteristics that we're going to look at with restrictive are things that actually cause overall changes in the chest wall. And so we've got some changes in the chest wall that can take place, like with, for example, obesity. We've got fibrosis that can change the architecture of the lungs themselves, and that's what this picture is showing right here. This is a trichrome stain, so all of the blue color is staining collagen, and this is within the lung tissue. And so all of this blue collagen is showing fibrosis of the lungs that shouldn't be present. You remember a similar type of stain from last week when we looked at fibrosis trichrome staining of the liver. You guys remember that when we looked at cirrhosis? So cirrhotic livers have a lot of scarring, and in a fibrotic lung, you see the same type of fibrosis or scarring. The categories, the second category would be acute or chronic interstitial or infiltrated diseases. These are going to be things like acute respiratory distress syndrome. So acute respiratory distress syndrome, ARDS, has a couple of different names. We call it traumatic wet lung, we call it lung shock, or we call it diffuse alveolar disease, DAD. So acute respiratory distress syndrome. This was a major cause of death of soldiers in Vietnam. In the 1980s, the mortality rate was about 50 to 60%. 50 to 60%. Now, it's down in the low 30s, upwards of 35%, so we've gotten much better. And, you know, you're saying, well, wait a second, I've never really heard of acute respiratory distress syndrome. Well, it's not very common in our country, and it's very problematic in third world countries. It can be extremely life-threatening. You've got respiration insufficiency because you're getting this damage that's occurring to the alveolus. And neutrophils are playing the primary role in releasing proteolytic enzymes. They release free radicals, causing trauma. They release prostaglandins, leukotrienes, that cause vascular changes to recruit additional cells to the area. Now, what can cause acute respiratory distress syndrome or lung shock? What can cause this type of disease that really only saw a high prevalence in the United States post-Vietnam when soldiers would come back? Well, there's indirect and direct methods of problems. So indirect methods are going to be things like septic shock, traumatic shock, or burns. These are things that can cause global problems to the organism, right, to the whole body. And then what ends up happening is you can actually get pooling of fluid within the respiratory tree. And then that can be a breeding ground for an infection to take place. Or directly, you would see things like pulmonary infections like SARS. SARS is a disease called severe acute respiratory syndrome. This is the one that was popularized a couple of years ago on customers that were flying from Asia over, and they were bringing SARS disease with them, and they were getting these respiratory infections, and it was extremely contagious because it became airborne in the airplane. So diffuse pulmonary infections, gastric aspiration, where stomach juices are coming up. A patient kind of vomits up a little bit laying down in hospital bed, and then inhales, and that content comes into their lungs. There's a lot of bacteria within the GI tract, even in the stomach. It's a pretty harsh environment, one to digest chemically and one to actually sterilize, right? And so gastric aspiration can cause direct injury to the lung tissue. Near drowning, because the patient is inhaling tremendous amounts of water, and that water could actually be infected with some bacteria. Chemical injury. Inhalation of a chemical that causes damage to the respiratory epithelium. Or, unfortunately, in other hospital settings, a mechanically induced trauma to the lungs if the respirator isn't set up correctly. So the picture that you're seeing here is a palm civet. Okay, this is a palm civet. These palm civets are actually a food source in China. And unfortunately, these are actually high carriers of this coronavirus. This coronavirus is shown at the bottom right. And this coronavirus is an enveloped virus that is got an RNA genome, and it has a ability to directly produce its own proteins and new genomes in the cytoplasm of a host cell. And so these palm civets carry these coronaviruses, and they transfer over, unfortunately, into the human population by eating infected meat. And then that patient actually has the virus within them. It makes its way to the respiratory epithelium, and then it can become airborne. So not as common in this country, obviously, but in certain parts of Asia, a few years back, there was sort of this scare that took place, and there were these travel restrictions that happened. I was actually traveling a lot during that time, and had to cancel some trips, so I did this prematurely. So what do these patients with acute respiratory distress syndrome look like? Well, they have shortness of breath, which is no surprise. They have tachypnea, which is a rapid heart rate. They're cyanotic because they're not breathing very well, so they have a bluish tint to them. They have hypoxemia. They have lung edema or fluid in their lungs. They're often non-responsive to oxygen therapy, because it's not really an issue of delivering oxygen. It's the fact that you've got inflammation and infection going on in your lungs, and you can't actually get oxygen across. So even if you increase the percent oxygen, it doesn't really do anything. And so this lung edema and this whiteout on this x-ray is shown here. So here's a patient you can kind of appreciate. So the black color is where the lung is, right? So here's this is the heart. Here's day 5. Here's day 10, and you can see how the whiteout is kind of growing. Look at day 13. So the right lung is almost completely full of infection and fluid. That's why it's called wet lung, because it becomes so wet on the inside. And then treatment-wise, at day 15, things are starting to clear up. Okay, so this would be the X-ray whiteout that we would see. Now, in our country, the most common cause of acute respiratory distress syndrome is actually going to be pneumonia, right? And pneumonia is most common and lethal in this mortality numbers that we're talking about in our geriatric population. So if you talk about older populations in nursing homes or in hospitals, and it's like so and so passed away. Well, what was it? What happened? Well, they actually got pneumonia. Like pneumonia. Like I had pneumonia last week. I took some antibiotics. I got over it. Had some turkey. I was good to go. Well, when you're an older patient, it's not easy to recover quite as well. Okay? So pneumonia is actually one of the most common causes in our country of acute respiratory distress syndrome. And streptococcus pneumonia is what's shown here. And there's a couple of different types of pneumonia that I want to characterize. And before I do that, let me just show you these pictures. And this is kind of a pretty cool slide, right? Kind of cool in a nerd sort of way. But here is an aerated lung. This is from the same patient. This isn't like Photoshop. This is an aerated lung, and here is an inflammatory infected lung with neutrophil exudate. Can you see the difference? It's like unbelievable. Like here, you can absolutely move air. Here, you're going to suffocate. You cannot move air at all. So pneumonia is an infection of the functional tissue of the lung parenchyma. And it can be bacterial, fungal, or viral. Now, the locations that can take place are either shown on the upper right. So we've got bronchial pneumonia, or that affect the bronchi, or we have lobular pneumonia. They're going to actually affect the lobes of the lungs. So here you have the lobular type, and here you have the bronchial type. And the lobular type manifests itself sort of in the entire lobe and has sort of this reddish appearance. And the bronchial pneumonia in the bronchi, so it's more punctate. So it has more of a grayed out appearance because you've got color in certain areas where the pneumonia is kind of affecting the bronchi. And in the non-bronchial tissue, you kind of have normal lung coloration. So you have gray hepatizing and you have red hepatizing based upon the different locations of the lung that is going to target. Now the types. The typical community-acquired type is bacterial. That's the most common. Now atypical community-acquired could be either fungal or viral. So we have to know, because a lot of times if a patient's non-responsive to antibiotics, then we move on and we sort of, it's the practice of medicine. Let's try this first. That didn't work. Maybe it's viral. So then we actually prescribe an antiviral versus an antibiotic. So atypical community-acquired is going to be viral or fungal, whereas typical is going to be bacterial. That's the one that we're most used to seeing. That was the one on this particular slide, right? This particular slide is bacterial, and the bacteria specifically is Streptococcus. Now, there are some other ones to be aware of pneumonia. Nosocomial pneumonia is actually a gram-negative, so this is also referred to as hospital-acquired. This is the type that you get in a hospital when you go in for, some procedures. Grandpa went in for a colonoscopy and came out with pneumonia. This is nosocomial pneumonia, hospital-acquired. Now, chronic pneumonia, as the word would suggest, is one that lasts for a long period of time. And the concern here is the mortality. If chronic pneumonia goes on beyond a few weeks, now the patient's at high risk of developing acute respiratory distress syndrome, and they can die. It can be lethal. Okay? And there's many, many other types of pneumonia as you move on in your studies that you'll probably cover that we will not have time to talk about today. What I want you to do is homework. This is a good study tool. I want you to think about this application. Maybe this is something you can do in SI. You got SI tomorrow afternoon, and then next week you've got 3 sessions, Monday and Tuesday. I want you to draw out, I know I'm not a drawer, okay? What I want you to draw out is characteristics of emphysema and characteristics of chronic bronchitis. So what I'm after is, I'm after this particular slide right here. I want you to be able to compare and contrast emphysema versus chronic bronchitis. So if you're not a drawer, I get it. Just make a table. and give me attributes of pure chronic bronchitis and pure emphysema, and be able to compare and contrast the two. That's going to serve you extremely well on the final in being able to answer those types of questions. Okay? All right. Have a nice week.